Good afternoon, everyone. Kirk Pluin. Sorry, we're just a few minutes behind, but we have a number of questions that came in. Our town council president, Maggie Zeidman, asked that we set this up with our infectious disease local expert, Dr. David Dodson. We were grateful to have him here today. We had a number of questions that came in. Maggie will be moderating those questions and asking them to the doctor. We have a couple of questions that came in that were more town related. I'll just knock them out real quick, and then I'll turn it over to our town council president. And actually, Ms. Zeidman may be able to add a little more content to these questions as well. So one of the questions that came in was how many positive cases within the town over the past 2 weeks fall in the 15 to 45 demographic? And then the second part to that question was how many cases were more senior? I can tell you on a regular basis, the town gets their information from the Palm Beach County Health Department, and they do not offer the breakdown of the age demographics. They only provide the number of active cases and an address. And at one time, there was even discussion about not even providing the address, but the public safety community had objected. They need that information because they are respond to calls to these houses, although they do take precautions. It would be nice to have that information so they could take additional precautions. So that's the only information that the town regularly gets. That is run by the county, the health department. So we don't have that, but it has been reported, and you probably read it in the newspaper, that a lot of the newer cases, and maybe Dr. Dodson later on can touch on this, have been skewing younger. For those that are testing positive, and then I want to mean younger, although everyone may not agree with this, I'm talking about under the age of 40. I'm not sure that even if we had the individual demographic information from the town of Palm Beach, that would be really useful because the average age here in town is 68. So I would expect that any of the cases that are coming from the town are going to be much older than the average from our counterparts in other cities. The second question that came in that was more town related was, will the town offer COVID-19 testing to the residents in the near future? So one of the first things that we looked at the start of this pandemic was bringing a testing site here to the town to offer that service. Chief Donato and I, mostly the fire rescue department, was completing that research, and so there was a number of things we were looking at. One is there was a great shortage, particularly at that time, of testing kits available, and then we had to explore the accuracy of these testing kits as well. And then there was the funding of it. Who was going to pay for that? Would that be put on the town? We were looking at state and federal monies available at that time, and also through private donations. By the time we were able to sort through all of that, a number of the federal government and the state government kind of kicked up their efforts, and testing sites and test kits started to become available throughout the county. They are readily available, to my belief, throughout the entire county. If anyone wants testing, we regularly send our employees that are exhibiting some symptoms to go get tested at one of these testing sites. You should also go to one of the labs, or really any of the medical facilities at this time to get tested. We will continue to examine the possibility of setting up a test site here in the community. But if that should occur, we'd have to work out through those details, including the financing and how that all works out. And that, again, if that should occur, that will occur later in this year. I have no more further questions that came in that would relate to the town government. The rest of them were all medical questions. So at this time, let me introduce our town council president and former director of nursing, Maggie Zeidman, and infectious disease expert, Dr. David Dodson. Maggie?
Okay, thank you, Kirk. Well, we have our own Dr. Fauci here. Thank you, Dr. Dodson, for being here with us. And the Civic Association, I thank you for being here today too with us, because it is being recorded and you can actually see us. So I invite everyone to take a look at this 1-hour session, a Q&A with Dr. Dodson through the Civic Association website. You'll be able to do that. Well, we're not doing very well in the county. We're not in a good place, and we're in a bit of a pickle. And the caseload has gone up 314% in this county in the last 8 weeks. And that basically is it's gone up 4 times in 8 weeks, 4 times what it was. Yet there has been more testing, and I'm going to defer the whole discussion of that to Dr. Dodson because he's very familiar with it. But I just want to make one point before we get into the questions. We tried to open up the economy here in this county by going from phase 0 into phase 1. And there were reasons for doing that. People needed paychecks, etc. But we didn't follow the advice that was given to us back in March. We didn't follow what we were supposed to do. And the main thing is you have to remain 6 feet apart. You have to be apart from people. You remember back to when we stayed home. Well, that's because the virus is out there and we're all susceptible to it. We do not have herd immunity. Most of us, I would dare say 98% of us have not had it. Could be 99% of us. So we had to flatten the curve back then. We figured that there was going to be a big increase in ICU admissions, and we needed to absolutely decrease the utilization of the ICU beds. We talked a lot about ventilators. You've heard all of this. But what you were supposed to do, and what I'm supposed to do, is to stay 6 feet away from people. Number 2, wear a mask. Number 3, wash your hands. Number 4, if you are sick, stay home. If you think you have symptoms of COVID-19, which is the illness, get tested. Call your doctor. It's very simple. So these were the things that we needed to follow. Don't congregate. We didn't do those things. I mean, I've seen picture after picture of young people huddled together. I was young once too, but you just can't do that in this environment. So I know I'm speaking to the choir because I think this town did a very, very good job. People were very, very careful. They ate outside at restaurants rather than eating inside. They tried to bolster the restaurants, the economics of it, by ordering in food. This is a town that comes together when it needs to come together for the good of everyone. And so I think we've done a great job, but we will see an increase in infections because the infections are following a track. And it is true that people who are infected will be here in this town. So again, social distancing, wear your mask, wash your hands, don't touch your mouth, nose, and eyes, know how to put your mask on and off because you can contaminate your hands. Every time you take your mask off, you wash your hands. So those are just some of the points that I wanted to make. But also to congratulate this town. You did do a really good job, and we didn't have any super spreader events, and that was most important. So, Dr. Dodson, you're going to do an overview of the pandemic. How do we get here? How do we get to where we are?
Yeah, well, thank you very much, Maggie, and thank you for having me back again. I appreciate it. And also, I just want to point out to everybody that we all were wearing our masks before we began talking, and we're separated by plexiglass, so we're following our own advice. Yeah, I think it's useful to sort of put into perspective what's going on in Florida and Palm Beach County, but into the bigger picture. So let's back up a little bit. So as far as pandemics, we knew pandemics can occur. In 1918, influenza killed 50 million people worldwide. In 2015, Bill Gates gave a TED Talk, and he told us that the next biggest threat to the United States was not a nuclear event, it was going to be an infectious disease event. And so we were kind of forewarned. And we've seen in 2002, we saw SARS, 2009, H1N1. In 2011, MERS came along, that's another coronavirus. In 2014, Ebola, and then subsequently Zika, and now in 2019, 2020, COVID. So we've known these can occur. We should have been prepared. In 2014, after the Ebola outbreak, President Obama created what's called a pandemic response unit, and they had a seat on the National Security Council. And their job was to prepare us for an event such as this. So, they would be the ones in charge when something like this occurred. And when you have a pandemic, what you do is the exact same thing as if you were attacked from a bioterrorism event, because you have to still get all the PPEs and diagnose and all that sort of stuff. So we had this in place, but unfortunately in 2018, this administration abolished the pandemic response unit. And that's one of the explanations why we've not had such a good response, because the people who would have normally done it weren't there. So this started in December 2019 in China, and very quickly they sequenced the viral RNA. And then we started to see outbreaks in places where the Chinese visited. They visited Iran, they visited Italy, and those were two of the earliest really hot spots. And subsequently, once Italy was getting going and it was appearing in Europe, a lot of Europeans went to New York. And so that's kind of why we've seen some of the places get hit as they have. So in January 21st of this year, the first case in the United States was identified, January 21st. On that same date, South Korea identified their first case. And in South Korea, they had a very vigorous national response, and they locked down everything, and the citizens used masks, the whole business. And so to date, in South Korea, about 300 people have died of coronavirus. Their population is about a fifth of ours. So if you want to compare apples to apples, you'd multiply 300 times 5, 1,500 deaths approximately to compare to the United States. In the United States, we have 125,000 deaths. So that sort of speaks to the fact that we have not effectively managed this pandemic.
Did, in South Korea, did they do a lot more testing than
Yes,
we have done? Yeah.
from the get-go.
So they did
Testing,
surveillance right from,
isolation,
yes.
contact tracing, masks,
The
everything.
same old principles.
Yep,
Test.
same principles.
Right.
Right. And so in the United States, the first, I think the signature failure of our country's response is a failure in testing. The CDC was supposed to develop a test. There were faults. There was a WHO test that we refused to use. And so we kind of floundered for the early part of this pandemic. And interestingly, there was a story in the New York Times last Sunday about a Dr. Rothy in Germany who was an infectious disease specialist, and she had a patient who got sick, was COVID positive, and his only risk factor was he had met with a person from China the week before who was asymptomatic. That person flew back to China and on the flight back got sick with COVID. And so she identified the first asymptomatic transmission, but there was a lot of resistance. People, national governments didn't want to hear that because they were checking thermometers and checking for symptoms. But if there's asymptomatic carriage, all that stuff is not doing the job. Mm-hmm. And so there was resistance to that initially. And so in February, it was kind of a critical month for us to be gearing up. If the pandemic response unit had been in effect, they would have been marshaling PPEs, marshaling ventilators, making sure testing kits were available, doing all that stuff to ramp up, but we just didn't have that. And the first death in the United States occurred on February 29th, although actually it may have occurred a little bit earlier in California. And Columbia, so as we went on through February, a Columbia University study has estimated that if the United States had instituted a national shelter-in-place, stay-at-home order at the end of February, we could have saved 83% of all the deaths in the United States to date.
That's quite a statistic.
It is. It's sad. And so by the end of March, then the United States had 81,000 cases, which we became #1 as far as the deaths in the world. So in the United States, our first case was on January 21st. By May 27th, we hit 100,000 deaths. That's how fast this thing has occurred. And in Florida, on March 2nd was our first 2 cases. It took it took 82 days to get to 50,000. And then from 50,000 to 100,000, which was June 23rd, there was 30 days. So the doubling time is getting shorter, and that's what you see on a curve like this. So for many reasons, we've not managed this well. And I'll just touch on, how do you manage this well? Well, the characteristics of managing a pandemic are you need early detection. There should be monitors all over the world. And we had this, but a lot of them were pulled back through cutbacks that this administration made. And you have to be prepared. You have to be ready to test, ready to have PPE, ready to have ventilators, and you need a coordinated national approach. And instead we've had 50 different approaches. And you also need a good public health infrastructure. The public health units have to be in place and serviceable. And universal health care is a prerequisite for having a good national response, because when people lose their jobs, they lose their health insurance. And so all of a sudden they have to struggle. And you have to have paid sick leave, because when workers are sick, you don't want them to have to go to work and spread the virus. And all of these things, we were lacking in. So in the United States, we were unprepared. We didn't have testing. There was a lack of federal leadership. Our public health system has been defunded over the last several years. The CDC, which normally would manage a pandemic, has been sidelined. We've kind of, this is the worst pandemic in the history of the United States, and we've kind of left it to amateurs, to politicians to run it. We should have let the health professionals run it, in my opinion. And then we also had pre-existing health disparities, so our population was not as healthy as it might have been going into this. The GAO said that our response has been slow, disorganized, and insufficient to protect the public. So we have a lot to learn, and we could have done much, much better.
I just want to make a point. You didn't mean that I'm an amateur as a politician, did you?
Of course
in
not.
terms of, I was just kidding you. But it is true that it has certainly been handled. No one knew what to do, it seemed like. And all of our news that we got was from, we held on to what Dr. Fauci said and Dr. Birx.
Right.
And they came up with a very good program for reopening. The only problem is we didn't pay attention to any of, I'm talking about Palm Beach County now in the state of Florida. We opened without making sure that we had met the benchmarks, for the metrics, where you have 2 weeks of decreased flu-like or COVID-19 illnesses, where you have continued decrease in or stabilization of utilization of ICU beds. And so we've learned, and we all learn as we go along through this, because not as if we've been through this before, I can even think of decisions that we've made, the commission, the county commissioners have made. There is a lag time, and we have to actually overreact, I think, in order to get this under control again.
Yeah, when you're managing a pandemic, you have to be decisive and you have to act very early. That's the most effective way. Once the curve has gone up and the numbers are going up, you've kind of lost the ball game. And in Florida, in May, we were averaging 725 new cases per day. Our state was opened up, and in June we've averaged 3,200 cases a day. It's just shot up.
Yes.
Because the virus, any opportunity the virus has to go from person to person, it'll take.
So if you had to list, so we know in the future, because this might happen again, if you had to list the things that have caused the increase, what would be your bullet points?
Well, it goes back to the biology of the virus. The virus can only do two things. It can infect people, and then it can take over their cells, and it can reproduce or replicate itself, and then those copies infect people. All the virus can do is infect, replicate, infect, period. So the way this pandemic evolves, it really is dependent on human behavior. It's what we do. So anytime people get together in close proximity, if they're talking, if they're sharing respiratory droplets, anytime we do that, that's the opportunity for the virus to spread, and it will. And so it's just we've given it this opportunity, and so when we lock ourselves down, it doesn't have much opportunity, and we flatten the curve. When we open things up and people get together in bars or whatever, the virus spreads. It's as simple as that.
Let's talk about the flattening of the curve for just a moment. We did this before, and we did it quite well in in March in this county, and especially in this town. But now we find ourselves right back where we're in a worse situation, I think, at this point. So we have to flatten the curve again. When you look at ICU bed utilization is up to 75%, hospital utilization. Can you tell us a little bit about that? What do we need to do? And tell us how the utilization is going.
Well, unfortunately, our choices are not great.
Mm-hmm.
We've done kind of a social experiment. We had a certain control of the pandemic. We changed our behaviors and we opened up our society. And when you do a maneuver like that, it takes 2 or 3 or 4 weeks for the numbers to go up. So you have to wait and see what happens. Well, we did that. So we opened up our society, and now we're seeing what happens. We're on a steep ascent of the curve. So, kind of, if we say let's keep doing the same thing and expect a different result, that's the definition of crazy.
Are you concerned, Dr. Dodson, about this and about the ICU bed utilization at this
I
point?
am absolutely concerned. Our hospitals are nearing capacity, and the numbers are skyrocketing. And so what we're seeing locally is we're starting to reach the breaking point. We're at a point where at least one of the major hospitals in the county is on the verge or may have closed its ER to further patients because they don't have enough capacity. So we're starting to reach the breaking point, and the numbers are still skyrocketing up. We looked at New Jersey and New York a while ago, and we're very concerned about them, but they said it can't happen here. Well, it's happening here right now.
Do you think that hospitals will start to go and put their plan into effect to reduce elective surgeries again, to start to get people out of the hospital, to open up COVID units? They had a plan in place in March. Yeah.
Right, so when a hospital sees this coming, sometimes they can convert some beds into more ICU beds. They have a little flexibility there. Sometimes they have to just open up the whole hospital to patients with COVID, and that means shutting down the profitable, elective stuff. So depending on the numbers, that's probably where we're headed.
That's very disheartening. And it is and I know people are frightened. I do think, though, if we work at this and we all do what we're supposed to do and we get more testing, possibly, would you say by September, October, we would be able to, hopefully, we will see the result of good behaviors now and good practices at this point. Is that a possibility?
Yeah, well, where we are right now is the numbers are shooting up, the hospitals are getting strained. So at some point, we're going to have to make some intervention. And that intervention is going to take 2 or 3 or 4 weeks to occur. So we have to wait and see. But we want to see the numbers going down, not up, before we start doing anything. And everybody's worried about school. The American Academy of Pediatrics says that we should get our kids back in school. It's healthier for them, for their development and socialization, everything. But it's also a way for the virus to transmit to other human beings. So we have to really look at the numbers very closely and see what we have to do.
Is there anything new in terms of symptoms or transmission of the virus?
Yes, so we've learned a couple things about this. I mean, the basics of how it's transmitted, it's still respiratory droplets, person to person, close proximity, some fomites, surfaces and things like that. But I think the big thing that we've learned is the asymptomatic transmission. That was not appreciated early on, and we're now seeing estimates of asymptomatic cases be somewhere 25 to 45, and there was one study in Britain that said 70% of cases were asymptomatic. So we have all these people with no symptoms who are out there spreading the virus, and that's been one of the big things that we've learned. When a person gets infected and they're asymptomatic, the data is that probably they're infectious for about 14 days. When somebody is asymptomatic, it seems like their immune response is not as brisk. So the virus sort of hangs on for a little longer, and in that way they're infectious for a little longer time than somebody who gets symptoms, has a vigorous immune response, and turns off the viral. replication. So 14 days of asymptomatic infectivity is what we've seen. Incubation period is about 5 days. We still, whether you're asymptomatic or symptomatic, we'd still quarantine for about 14 days. That seems to be the approximately the right number. And then we've seen cases already. We've seen a choir where one person infected 52 people. We've seen a Zumba class where an instructor infected 100 people. We've seen a seafood plant where one worker infected 500 people. So this, and we have these, there's something called super spreaders. There's been estimates that about 10% of the people can cause 80% of the infections, especially if they're asymptomatic. So the spread is out there, and again, it's just up to our behavior to stop.
Is there something specific that you can point to about the super spreader event? I mean, of course, people may be bunched together, congregating together, and not having a social distance of 6 feet. But does it have anything to do with the fact that there was singing or that someone talks loudly?
Yeah, so there's a lot of variables about how infective you are. There's a time course that when you're first infected, you have a low viral load. It usually peaks around 5 to 7 days, and that's kind of the optimal time for testing after you've been exposed to make sure you get a positive culture if it's positive, and then it gradually goes down. Usually by a couple weeks, which is usually the time when the antibodies start kicking in, you start seeing the viral load go down. And then when people, we've seen that it can be transmitted just by talking, but when you're singing in a church choir, when you're yelling at a football stadium, when you're exhaling deeply, that is an increased risk of transmission.
Mm-hmm. Well, part of the problem here, of course, is the asymptomatic transmission, and that's why we're wearing masks.
That's correct.
It's the ethical decision to make to protect others
from
you.
And there should be no question that we should all be wearing masks in public, period. I think at this point it's irresponsible to recommend otherwise.
And I take my mask with me when I go outside, because the rule is if you can't be certain that you can be 6 feet away from someone when I go to take a walk to get some exercise, so I always have it with me. And if someone's coming toward me, I put my mask on, and I put it on correctly.
Yep.
And then I can take it off and take it off correctly. But boy, when you get home, you better wash your hands, because you certainly don't know what's on your mask, on the inside or the outside. But I think that the mask is extremely important, and I congratulate the Palm Beach County Commissioners for making that decision. It was a 7-0 vote. They did the right thing. And we are, as this town, we are very appreciative. It would have been very difficult for us, the tiny town, to do that without the support of the county. So I think that's a very important thing.
Yeah, Maggie, one other thing. You know, we look around and we live in paradise here, but we're in a hot zone.
Yeah.
The virus is amongst us and everywhere you look. And so I tell my patients that if they do venture out, just assume that any other human being is infected and then act accordingly. And that's maintaining the distance, wearing the mask, and the whole business.
So with symptoms, are there any new symptoms?
Yeah, so there's something that I call the COVID journey. When somebody gets infected, a finite amount of things could happen. So when somebody, and we can't predict in any one person how it's going to play out, but when somebody is infected, a large percentage of them will be asymptomatic. They'll be fine, clinically well, spreading it, eventually get over it. The other people will develop symptoms. And in the people who develop symptoms, some will be mild. They'll be at home with a flu, fever, coughing, feeling lousy, and then eventually they'll get over it. And then a portion of that, their breathing will get worse, they'll get a viral pneumonia, they'll have to go to the ICU one day. I'm sorry, the hospital one day. And then once people are hospitalized, most will recover, some will end up in the ICU, and some of those will die. So it's kind of like a, like a little diagram. And when you put a lot of numbers in the front end, the numbers on the back end are going to go up. So the more cases we have, the more hospitalizations and deaths we're going to see. It's just that's the way it works. So the COVID journey, yes. So as far as symptoms, so here's what can happen. Most people will get an influenza-like illness, fever, cough, shortness of breath, muscle aches, fatigue, sore throat. Those are the symptoms that we've seen from the beginning. And then there can be different organ system involvements. The most prominent is the lung, because there are certain receptors in the lung that's where the virus attaches to, and that's where it attacks. So you get a viral pneumonia, you get an inflammatory response, and then some people will get what's called ARDS, and they'll need a ventilator, and that's what's going on there. In New York City, they did a study of 2,600 patients. 14% of them went to the ICU, 21% ended up dying. So it's a significant number. And what we're learning now as this goes on is that particularly with people who have been on the ventilator for a long time or have had a severe viral pneumonia, there may be long-lasting permanent lung damage that shows up. We're going to have to see how this evolves out as we go out. Cardiac injury, we typically see an elevated troponin, which is an indicator of myocardial injury. So we can see viral infection of the heart called myocarditis. We can see heart attacks, and then you may have some sequela from that. There's GI involvement, nausea, vomiting, diarrhea. We've seen that. Neurologic involvement. About a third of patients have either headaches, loss of consciousness, confusions, altered mental status, and some people have acute strokes. And a lot of people have an interesting symptom where they lose their sense of smell, which is mediated by the olfactory nerve, which is part of the nervous system. And so, and there's also the hematologic part. We see increased coagulability. So the virus may work on the endothelium, and it may set off a cascade where we start to see more clots. So we see DVTs, deep venous thrombosis, we see pulmonary emboli, we see acute strokes. So thrombosis is a big injury, and so it's evolved that once people are in the hospital, they usually get put on an anticoagulant to prevent that. So that's kind of the system rundown of what can happen.
That was excellent. It's very scary too, because we simply, we don't know what the sequela will be long term from having it. You can feel like, okay, that was bad, but it may stay with you in some fashion for some time and hurt organs like your lungs, your heart. Myocarditis is a bad thing to have. Can we talk a little bit about young people? So Kirk we had talked about this earlier. The average age back in April was in the mid-60s of people who were being admitted and who were positive, let's say, put it that way, who were positive. Those, of course, were people who had symptoms because that's who we were testing back then. Now we're testing a lot. Anybody can get a test. You don't have to have symptoms. So the average age now for positive tests has dropped here to 37. So do these younger people also get very sick and wind up in the ICU? And what happens to them?
Yes, that's a great question. So what we've seen is an evolution to younger cases in the hospital. And in Florida right now, 17% of all the patients that are hospitalized are under the age of 45. So if you think you're below the age of 45, which is, I guess, the definition of young, it keeps going up as I get older. But if you think you're going to get off scot-free if you get this wrong, 17% of the hospitalizations are under the age of 45. 84 people in that age group have died. So we're seeing this. And one of the interesting clinical observations is that when the younger people get into the hospital, they're staying longer, on average of a couple weeks. And so you have these sick young people, and we're seeing all these young people, all the young cases go up. They get in the hospital, they stay a long time, 2, sometimes 3 weeks, and that clogs up the hospital. So those take up beds for a longer period of time.
Why do they stay longer? What's going on?
Well, the mortality, the death rate is lower than if they were 65 or 75 or 85. But it takes them longer to survive, basically. So most of them do survive, but they're fighting for a longer period of time.
I understand. You don't have bed turnover.
Right. And so that's where the hospital capacity gets clogged.
Well, there's a friend of mine too had a friend of hers whose son has had high creatinine levels. What does it do to the kidneys?
Yeah, so, well, when you're in the ICU with any illness, it puts a strain on all the organs. And early on, they were seeing ARDS, which is excess fluid in the lungs. So early on, the thought was to dry them out, to keep people on the dry side. But that dehydration leads to acute kidney injury. So now we've learned to keep them more hydrated, and that's decreased the kidney injury. But the virus, either indirectly through dehydration or decreased blood pressure or something like that, can affect the kidney. And there may be some direct viral effects on the kidney, although the number of receptors in the kidney is not as much as in the respiratory tract.
I see. Okay. That was a question that came to us, so I thought I would ask about that. How about, should we move to the testing?
Sure.
Okay. So what's new in terms of testing and the diagnosis of coronavirus, which is, if you hear SARS-CoV-2, that's the new novel coronavirus. And the COVID-19 is the illness that it causes. So what are we doing in terms of testing, either the swab, which looks at the RNA, and then maybe also a little bit of an update on the antibody testing and antigen testing? Okay.
Yeah. So to diagnose a COVID infection, the gold standard is a nasal swab, PCR, which amplifies the genetic material. Again, it depends on how well you do it. You should use both nostrils to maximize your exposure. The timing can be affected. But if you get a positive PCR, that's very highly specific that you have a diagnosis. So you may get some false negatives, but a false positive is unusual. So that's kind of the gold standard. Now there's something that's been approved by the FDA that was just approved in May called the antigen detection system. So the advantages of this is that it's a point of care test. It takes about 15 minutes and it's a lot cheaper than doing a PCR. So what it is they take a little part of a viral antigen and they look for that in this test kit. And so if you have a positive antigen test, it's very, very specific. The problem is that it's not very sensitive. It's maybe 70 to 80% sensitive. So there's a high false negative rate. So if you have a patient come into the ER and it looks like COVID and he has pneumonia, you could do one of these tests and get an answer very, very quick. But if it's negative, you haven't necessarily ruled it out. So in that situation, you'd probably go ahead and do the nasal swab, the PCR, to keep looking for the virus. So, so the antigen detection, there's pros and cons. It's quick, it's cheap, but it's not as sensitive, or not as sensitive as it might be.
Is there a quick test for the nasal swab?
Not at this point.
No.
No, it still takes, the turnarounds are, well, 24 hours or longer, depending on the lab. And then antibodies.
Yes.
Okay, everybody wants to have antibodies. Problem is, normally when you have a viral infection or any infection, you develop your antibodies. That's your body's way of fighting off. We don't know that the antibodies at this point will prevent you from getting a second infection. We just don't know that. It may, hopeful. We don't know how long the antibodies will last. It may be several months, maybe up to a year compared with other coronaviruses. The MERS antibodies lasted for about 2 years, but that was a more vigorous response. So right now there are about 60 antibody tests that have been approved under the EUA, the Emergency Utilization Act of the FDA, and some of them weren't very good initially, so some of them are beginning to fall by the wayside. You'll get antibodies usually about 2 to 3 weeks after your first symptom or you're infected and you don't have any symptoms. So the uses of the antibody test if you want to find out if somebody's had a previous illness, if you want to do a survey in the community to find out what the community prevalence is. If you want to, if your person's interested in donating convalescent plasma, you have to have antibodies for that to work. So that may help. And then as we talk about vaccines in a minute, antibodies are a measure of if the vaccine is working. So when they do vaccine trials, they're probably going to be looking for antibody responses. But again, we don't know if the antibody responses transmit to clinical protection. So, and then just throw there's no universal standards for these antibody tests. Each lab has its own different quirks and everything, so we haven't made a uniform antibody test at this point. And then, you know, if you're positive for an antibody, that could be a pre-existing condition. So if we lose that protection in our healthcare system, that could be an issue down the road.
I had not even thought about that.
Yes, there's a lot of issues about this. So that's the antibody test.
Thank
Yes.
you. And now treatments.
Treatments. So, okay, so we're getting better. We're getting better at treating people who have severe COVID infection. The new news is dexamethasone, steroid treatment. The Oxford group did a randomized controlled trial, and it involves 11,500 patients in the UK. And they had arms. They had a dexamethasone arm. They've had a Kaletra arm, which is the HIV antiviral. They've had azithromycin. They've had Actemra, combination plasma. So all of these arms are in progress. But the dexamethasone arm showed clear benefit. So they stopped it prematurely, and they came out with the recommendation that dexamethasone be used in treating severe people. So the dose is 6 milligrams per day for 10 days. And that's equivalent of about 40 milligrams of prednisone for that period of time. And what they do point out is that there was no benefit if you were asymptomatic or didn't require oxygen. So if you're just sick at home, there's no benefit shown.
So what does that mean?
That means if you're bad enough to require nasal oxygen or a ventilator, then there will be some benefit of treating with dexamethasone. So basically, people shouldn't be taking this at home. No benefit.
Good point.
Yeah. So dexamethasone. So that seems to be part of our armamentarium. Now we also have an antiviral drug called remdesivir. Again, that's an intravenous antibiotic or antiviral medication. So we're now using this for same population, the hospitalized, sick, oxygen requiring group will get maximum benefit. What we've learned is that if you're on nasal oxygen, about 5 days of treatment will usually be enough. If you're on a ventilator, the recommendation is for 10 days of treatment. And that's going to become an issue as more and more people want remdesivir, and we have a finite supply. So we're trying to marshal the supply that we have to the maximal effect. So that's remdesivir. And then we have convalescent plasma. So when people have been infected, they develop these neutralizing antibodies. You can go to a local blood bank and donate your plasma. It can be distributed to people with COVID infection, and it seems to help. Clinical trials are in progress. We'll see. But some of the early things, and including hydroxychloroquine, don't work, so we don't use them.
And you're not putting people on ventilators as early as we did in the beginning, is that correct?
Yes, so we've learned with ventilators, we've learned to try and keep them off as long as we can. We've learned to put people on their stomachs to maximize their oxygenation capacity in their lungs. So these little tricks, and we've learned to not dry them out too much. So these little tricks of patient management we're learning, and that's translating into improved survival.
Good, very good. Vaccines, is there development coming along? Is there something we can hang our hat on?
Yes, vaccines, that's the magic bullet we're all hoping for. So when you're developing a vaccine, there's 3 things to look at. One is safety, first and foremost, because if you're giving something to a lot of people, you want to make absolutely sure it's safe. You're not doing any harm. And then you have to look at immunogenicity. When you give a vaccine to a person, does it provoke an antibody or some sort of immune response. And then you have to go out in the real world and give it to a lot of people, a lot of different people, not just healthy volunteers, and see if it actually works. And the phase 3, that part is what takes the longest time, because you have to give it to a lot of people and you just have to wait and see what happens. And right now, in certain countries where the number of cases is going down, they can't do the vaccine trials because they don't have enough new cases. So now they're going to Brazil, they're going to South Africa, where people are on the upswing, and they have to give the vaccine to people before they're actually exposed. And then they have to see what happens. So those trials are in progress right now. There's about 15 different vaccines that are currently in trials. So there's, as far as vaccine types, there's an inactivated vaccine, which is like polio. That's only occurring in China. There's 2 companies in China that take the coronavirus, inactivate it, and then inject it into people and then see if they're developing an immune response. And then the other type of vaccines are what are called subparticle vaccines. So the Oxford group has a vaccine like that. They have made an antibody to one of the spike proteins, and that's what's in their vaccine, and they're taking that to Brazil and South Africa and seeing if that works. In the United States, the NIH and a company called Moderna is using another part of the antigen and just injecting the RNA of that, and that's their virus. So right now we're looking at any of these different types of vaccines. We don't know which one's going to work, so we should do trials with all of them to see what kind of leads we get. So that's kind of what's happening right now. And we all hope that vaccines are coming. The only way this pandemic ends is with herd immunity or with vaccines. But I think December is unreasonable. My opinion is it's going to be at least until 2021 sometime if we get a vaccine. And then once we see that it works, and then we see that it's protective, clinically protective, then it's going to be a distribution problem. And the other issue, I mean, vaccines are not, it's not an easy thing. People just want a magic thing and just to solve the problem immediately. But when people get COVID infection, there's something called a cytokine release syndrome, CRS. So what happens is the COVID virus in certain people, we don't know why or who, sets off this immense inflammatory reaction that involves their entire body, and particularly their lungs. A lot of them go on into full-blown pulmonary failure and then die. So suppose we inject, as part of a vaccine trial, suppose we inject one of these antigens to a lot of people and set off this cytokine storm in people who are otherwise healthy. We don't know if that's going to happen. So there's a lot of slips between the cup and the lips as far as vaccine development. So we're hopeful. Everybody's working on it all over the world, but it's going to take time to be sure that it's safe and it works.
So thank you for that. I know that those who are listening might be a little bit disappointed because everyone does talk about the vaccine. Next year we'll have the vaccine, everything's going to be fine. It's probably not going to work out that way. And I would think that the first people to get the vaccine are probably going to be the people in the healthcare system because they're taking care of the patients. So there's going to be a triage of how you give a vaccine to, but that's once you establish the efficacy and that it's safe.
Yeah, so I mean, normally you'd say, well, the highest risk group of dying is the elderly. They have a lot of comorbidities. Do you really want to give your vaccine first to them because they're most likely to get side effects or problems? So we have a lot of things to figure out between now and then.
My grandson this morning said, Nana, when I have a child, there will be a vaccine for this. I said, yes, there will. That's correct. Well thought out. Yes, there will.
Well,
before that.
In 2002, SARS, which is a similar coronavirus, everybody was worried about it. They said, let's get a vaccine. They started to develop a vaccine, and we don't have a vaccine. So I hate to be a party pooper here, but there's a possibility that we may not end up with a vaccine.
That's not a hopeful statement. Okay. Now we have some questions. I just want to make sure we've really covered everything. Oh, I do want to ask you about this, because some people are concerned about this. I get it. Stanford researchers recently pegged the mortality rate of COVID-19 to be 0.26%. Is this, in this statistic, they made an assumption of a 35% rate of asymptomatic cases, 0.26% mortality rate. In Florida, we're at about 3% right now. And, you know, worldwide, nationwide, it's more like 4 to 5%. So can you really apply a single fatality rate? Isn't that a little bit simplistic because it depends on other variables, and how are they coming up with this 0.26%? It makes people feel like, wow, this is all just a hoax. It's really not that dangerous. You know, I'm not going to die from it. They're making too much out of this. Can you address that?
Yeah, so there's a lot of moving parts to that question. Stepping back, the mortality rate is basically the number of deaths divided by the number of cases. So if you look at the big numbers, right now in the world, there's about 10 million cases and about 500,000 have died. It's about a 5% mortality. If you look at the United States, we have 2.5 or a little over that million cases, 125 or so. That's about a 5% mortality. The problem is that for every diagnosed confirmed case, there's X number of other cases that have not been tested and diagnosed. So, and when we're trying to figure out a proportion like this, and we don't know the numerator, numbers can be all over the place depending on the assumptions that you make. So most people think that the mortality rates is around 2% or so, which is the influenza mortality rate is 0.1%. So it's like 10 or 20 times what influenza is. So it's not just the flu. But as far as these numbers, it depends on what assumptions you're making, what data you're using, and that's, you know, so people can come out to basically any conclusion they want by massaging the assumptions.
I remember, I read the 1918 pandemic. The mortality rate for that, I think, is less. Do you know what it is? I don't.
Well,
I had it
I mean,
written down
50
somewhere.
million people died.
Right.
The population of the Earth was a lot less.
Yeah.
So, you know, the number.
The point of this is that this is something to pay attention to, not to downplay by grabbing onto a statistics that you might read when most of the medical literature is really saying it's 5%. And it really depends on what group we're talking about, too. Are we talking, because then you get into subgroups.
Right.
So this is a very, very dangerous virus that is very easily transmitted, that has an asymptomatic, huge asymptomatic component to it, and pre-symptomatic component. So it's people are getting infected. That's the reason why I brought that up. So we have some questions for you, too. One question is, what about this type A that we're hearing about? You smile. That's what my daughter, I could tell she was smiling, practically laughing on the phone. But people are now, some people want to go get tested to see what type they are, because I don't know if we'd actually call this research, but what was published was that type A, people who have type A blood are more prone to getting coronavirus and they get sicker. So what do you think about that?
That's true. So people want to know, if I get coronavirus, what are the bad signs that I'm not going to do well? Well, we know there's a few of them: heart disease, advanced lung disease, COPD, obesity, diabetes, and then this study came out that if you had type A blood, they did a little bit worse. The effect was mild. It wasn't a huge effect, but it was a difference. And they found that type O blood did a little bit better, for whatever that means, for whatever, you know, however that came about. But other risk factors include being black, Latino, or poor, and those probably have they're probably a stronger effect than type A blood.
Okay, thank you for clearing that up for us. Let's see, we answered that. See, a lot of times we answer a lot of these things as we go along. Thank you, Dr. Dodson. Testing and contact tracing. Here's a question that's posed. You receive a call from a friend who gives you the unwelcome news that they have tested positive for coronavirus. I say good on them that they called you to let you know. You were just with them a week ago outside at the beach watching children jump waves. You were together for about 20 minutes, sometimes several feet apart, other times closer. Do you need to be tested? And should you call folks that you have been with?
Well, we get that question all the time in the office. The CDC definition of a significant contact is if you've been in close contact that is less than 6 feet for more than 15 minutes. That's a significant contact. So if you're with somebody who subsequently tests positive, yes, it makes sense that you should be tested because you're at higher risk than somebody who's been sitting at their home. I think you should be tested, and if you've not been in contact with anybody else, that it can end there if you're negative. But if you turn to be positive, then any of your contacts need to be tested also.
Okay. Should you let people know before you even go to get tested? You know someone who is now positive, and you were with them. Do I have the responsibility now of calling people to let them know that I was with someone who is now COVID positive, has the coronavirus?
Well, that's a difficult question.
It
I
is.
think if you have the test and it comes back positive, absolutely.
Okay.
If it comes back negative,
Well, then you're good.
then you're good.
Yeah.
So it might be premature. It might be better just to wait on the test and then act accordingly.
There's no change to the 14-day quarantine, correct?
No, whether you're asymptomatic or symptomatic, the infectivity seems to be about 2 weeks.
Okay, let's talk for a few minutes about children. There was a study done, but I think it has a flaw in it. It seems the spread is from adult to children, not the other way around. I don't know, Dr. Dodson. I mean, children have been home now for 4 months, so it's kind of hard to know if that's really accurate. So how do we make sense out of being with children?
Well, the spread is from infected person to non-infected person, period. No matter whether
Children
you're
or
young
adult,
old.
yeah.
If you're infected and you have virus and you're in contact with another person, that's how it's transmitted. So the virus is looking for any opportunity it can, doesn't care who it is.
So staying with the little ones for another question, there's a growing concern about multi-system inflammatory syndrome, which is something that's been emerging and noticed in children with COVID-19. What is it and what are the symptoms?
Yes, so it's called MISC, and the CDC definition is a person who's younger than 21, who has a fever, who has markers of inflammation, CRP or sed rate or something like that, has a severe illness, and has multi-system involvement, that is cardiac, pulmonary, renal, skin, GI, pick two, whatever it works. And they either have a positive PCR or they've had a recent exposure to somebody with COVID. Mm-hmm. And what we see is that this is a severe inflammatory syndrome. It may start weeks after the exposure or the infection. Oh. So mm-hmm. There may be a lag time. So the kid may be doing fine, and then all of a sudden, boom, this happens. The treatment is supported. IV fluids. Sometimes we're giving steroids or gamma globulin, sometimes aspirin. But the fortunate thing is that deaths are rare with this, even though it's a very severe illness. That's
very good news, because I know people are concerned about it. What about testing and contact tracing? How are we doing with contact tracing? I know that the state has sent in a lot of contact tracers into the Department of Health. Dr. Alonso told me that, and she's requested more. But if we don't have enough contact tracing, we don't have enough testing, and we don't have enough contact tracing, we can't get a handle on this.
Right. So, the way to contain an epidemic is you identify cases with testing, and once you identify a case, you immediately contact that person, quarantine if necessary, and then test all their contacts. unfortunately, our public health system has been underfunded, so the public health departments don't have a lot of extra manpower to do contact tracing, so we're trying to ramp that up. In Massachusetts, I think, is one of the best public health systems. And the problem there is that they've been doing some contact tracing, but they found like that 40% of the time people don't answer their phone. So they can't go too much further than that. So there are real world limitations to the contact tracing as it exists right now in the country. So we're a little behind on the 8 ball as far as contact tracing, which is what we look to contain an epidemic.
But we're going to ramp that up, right?
We're trying to right now.
Yes, so, and
Contact
I know
tracing.
she's working very hard on that. I think she had 20 some, and then she had another 30 in, and it's getting it up to like 70 people who are doing
Right.
contact tracing.
Well, eventually, whenever this curve starts going down, we'll reach a point where we will start again thinking about loosening up restrictions and everything. But the caveat is once you're down at a low number, you keep testing, and then the minute you find a positive, you jump on it and try and tamp it down
Right.
before it's letting the fire go again.
Thank you. Then let's see. Here's 2 questions for you. Is a person's reaction to COVID-19 based on how much exposure they may have had or solely immune related? Meaning, slight exposure to the virus could still lead to a serious, possibly fatal reaction.
That's a good question. So when people get infected from another human being, either asymptomatic or symptomatic, they get a load of viral particles, and then that journey there depends on the number of viral particles and their immune system. There's an interplay. And what we were seeing early on up in New York is that the bigger the viral load you get, and that was particularly healthcare workers who were exposed to these patients in the ICU and intubating and everything, they were getting a bigger viral load and they were getting sicker quicker. So there is a component of viral load, but once you're infected, it's kind of hard to tell whether the infection itself is going to be severe or not.
Okay. Now, here's a question. What percentage of ventilators are available, and what percentage of patients are on ventilators in Palm Beach County? Well, we talked about ventilators a little bit earlier, in that that's not the first go-to, but if you'd like to take a crack at that question.
Well, part of the problem in Palm Beach County, or in Florida, is that Florida does not report the daily number of COVID hospitalizations.
That's right.
That would really help us to know exactly what's going on any one day. They report a cumulative number, but to answer a question like that, you need to know exactly who's in the hospital there on any one given day. In Palm Beach County, there's a total of, I think, 400 ICU beds available, and they have there's some service that's been running the numbers, but we're running like 70, 80,
Yes, that's right.
90% capacity, and there's one hospital that's at 100% capacity and may shut down its ER. So it's kind of a localized thing that you have to look at where you are at what particular point in time.
At present time, we have enough ventilators. That used to be the concern. So we get a report every Friday. And so there are enough ventilators. It's the ICU beds, where you have nurses and doctors who are going to be able to provide that kind of supportive care to get you through the very acute phase of this. So that's a question about ventilators. That used to be the big deal, but I think they have enough ventilators, but it's the ICU beds. As you said, the ER closing off and saying, no more.
No more.
It means your ICU is full, 100%, over 100% probably. It's 100% utilized, but you probably have patients in the ER who are waiting for beds in that ICU. That's why you close the ER. So it's it's an ominous sign.
Yep. Thank you, and I'm going to take this opportunity on behalf of the healthcare workers to say a word. So we tend to focus on hard numbers like ICU beds or ventilators, but there's a human part of this. There's nurses and doctors who are doing their job every single day, and there's a finite amount of those people. and we're overburdening them by our behaviors. So, it became a fashion for a while to go out and hit a pot or something to show your appreciation. Well, if you look at the interviews with the healthcare people, what they're saying is, folks, stay home, wear a mask. Don't make me work like this. So if you really want to respect and appreciate your healthcare workers, listen to the ways to prevent infection.
That's an excellent way to end this, because that is so right on the money. Our daughter is a doctor, and when I think of the fact that she will go through this every 2 weeks at Mass General and our son-in-law is a doctor, that they're going to be dealing with this for the next year, it's of concern, and yet they do it so willingly. They never absolutely going to be there for us. So we have to be there for them by doing what we're being asked to do.
It's the least we can do.
It is the least we can do. Well, Dr. Dodson, thank you very, very much. I really do we all appreciate that you take your time and you come here, and you always come so prepared. I see all of your notes. You want to give us the very best information and the latest, and you do. And so we very much appreciate that.
So Maggie, thank you very much. It's my pleasure. I appreciate it.
Okay, thank you. Thank you, everyone. I hope you'll listen.